my name is Anita Gulmiri. I'm faculty at the New England College of Optometry, and I see patients at our flagship location at the New England College of Optometry Center for Eye Care, where I'm heavily involved with our myopia control clinic. So for today's talk, I do want to focus on an introductory overview of orthokeratology within the context and backdrop of myopia control or myopia management. And before I get started, I do want to thank Contomac for sponsoring this wonderful and educational initiative, and I hope that you can walk away today with a few pieces of knowledge and some clinical pearls. So orthokeratology works to temporarily correct refractive error. A rigid gas permeable contact lens is worn overnight to reshape the corneal curvature so that during the day there's little to no dependence on refractive correction. More often than not, we're using this type of treatment to correct for myopia, but it can be used to correct for hyperopia and in some cases even presbyopia. Other names of orthokeratology that you may have heard of are corneal reshaping, and treatment systems and lens designs that you may be familiar with are corneal refractive therapy and vision shaping treatment. Here's a figure that is a great illustration of the effects of ortho-K lens wear on corneal anatomy. One theory behind ortho-K is that fluid within the central epithelium is compressed. So there's no loss of cells and no cells actually move, but the fluid within these cells moves and gets dispersed. So this graph here presents the changes in corneal thickness broken down as total, stromal, and epithelial over a 90-day period. As you can see, there is a overall total central thinning over this 3-month period, but interestingly, at day 1 is where we're seeing the steepest drop and most significant change in corneal thickness, and that continues to stabilize until about day 10, which is approximately the average time, we give to our patients in the myopia control clinic on how long ortho-K treatment will take to reach full correction. The other point I want to make here is that you can see that the epithelium thinning is what accounts for most of this total central corneal thinning, and that there's no significant contribution of central stromal thickness changes that are seen here. So essentially, we're able to kind of see here that majority of the changes do occur in the first 10 nights of wear, and that most of these effects are on the epithelium. Very little, if any, stromal changes are actually observed. So indications for orthokeratology, by far the most prominent and widely used indication for ortho-K is myopia. Ortho-K treatment gained FDA approval in 2002 for the correction of myopia. The US FDA is actually the United States Food and Drug Administration, and it's the regulatory body that controls medical device use amongst other products as well. Now, although the FDA has approved myopia treatment, this is not the same as an FDA approval for myopia control with orthokeratology, which in fact, until very recently, we did not have. So this development is so recent that that specific ortho-K product that has been FDA approved is still not available for clinical use. So in our myopia control clinic, when we do present the idea of ortho-K to our patients and their parents, we're explaining the difference of myopia, of FDA approval, and ensuring that they understand that it is FDA approved for the use of myopia correction, but not myopia control. They do sign an informed consent form as well, that they're agreeing to this off-label form of treatment for myopia management and myopia control. So the FDA has allowed for myopia correction up to 6 diopters with the CRT design and 1.75 diopters of astigmatism. With the VST design, up to 5 diopters of myopia and up to 1.5 diopters of astigmatism. Of course, you can go beyond this range as well, but again, it's considered off-label. Off-label, there's been reported cases of high myopia being corrected up to 10 diopters. The other thing to note is that in the US, there is no age restriction. So the youngest child we fit with ortho-K is 5 years of age. Other indications do include hyperopia and presbyopia, but these again are more difficult to treat, and there is no FDA approval for either of these treatments. And then lastly, we kind of touched on this FDA approval in 2021. Hopefully we'll have FDA approval for the use of ortho-K for myopia control. All right, so We know we can correct myopia quite easily, so what's the big deal? Well, the importance of myopia management lies with considering the prevalence of myopia, which is rapidly increasing, not only across Asian and South Asian countries where the incidence is, of course, the highest, but also across the world. And that's a scary thought when we consider the implications of high and degenerative myopia. Myopia was declared an epidemic by the World Health Organization a few years ago, and currently it's estimated by the year 2050, that is, if we don't do anything to prevent it, more than half of the world's population will have myopia. That's 5 billion people. And another scary number of that 5 billion will have high myopia, and that's equivalent to 1 billion. That's 20% of that 5 billion that'll suffer from high myopia by the year 2050. So going back to the question, why should we care to do anything beyond just correcting for myopia? So let's consider the impact and consequences of myopia. And I hope this will kind of allow you to understand the urgency and even the obligation we have as eye care providers to do more than just correct for myopia, but to also consider ways to slow down progression of myopia and to contribute in preventing the onset of myopia. So first, we have to consider the vision-threatening conditions as a result of progressive high myopia. When I say high myopia, this is referring to greater than 6 diopters of myopia. Understandably so, with the increase in prevalence of myopia, we're also seeing an increase in prevalence of myopic maculopathy, which is now one of the leading causes of blindness, which is generally not treatable. Once we get to a point of legal blindness with these patients, our only option is to refer these patients for low vision rehabilitation services, at which point their quality of life is significantly impacted already. Now, according to a recent paper by Bullimore and Brennan, each diopter increase in myopia results in 67% increased risk of myopic macular degeneration. Although the condition does develop later in life, the underlying myopia develops in childhood. Again, that's more reason to kind of get on board with myopia management earlier on. And then we all know that retinal detachments as being highly associated with myopia. The risk is, of course, higher with higher myopes, but it's also high even with moderate to low myopia. It's 9 times higher with moderate myopia and 3 times higher with low myopia of about 1.5 diopters when compared to emetropia. And then high myopia is also a risk factor for glaucoma and PSC cataracts, although arguably, these tend to be less devastating than myopic maculopathy and retinal detachments. Higher amounts of myopia can also affect candidacy for refractive surgery. So for these patients with higher myopia, thinner corneas, or both, these patients can be poor candidates for LASIK because of the increased risk of postoperative corneal ectasia. So not only do patients with lower amounts of myopia tend to have more options for refractive surgery procedures, they tend to have better postoperative outcomes when it comes to refractive surgery as well. And then general impact on quality of life. Having blurry vision is no fun. And so when we think about these patients, generally there is a greater dependence on whatever mode of correction, and sometimes a greater disability in that manner as well. And lastly, the financial and economic burden. There is an increase in that when it comes to higher rates of myopia, when it comes to covering costs of correction, but also surgical interventions for things like retinal detachments, cataracts, cataract surgeries, etc. And now just to touch really briefly on the long debate between genetics and environment and how that kind of relates to myopia and its etiology. Much like other disease processes, the two kind of do go hand in hand. There is this interplay between genetics and environmental factors when it comes to myopia development. We know that the prevalence is higher in these patients whose both parents are myopic, suggesting that genetic factors are clearly involved here. And for decades, there has been the dominant view discounting kind of other reasons for myopia. However, more recently, population-based studies are suggesting that the environmental factors may be actually playing a majority of the role here, especially given the rapid increase in prevalence of myopia over just one generation. And this is shown in many studies, but basically this indicates the strong environmental cause because, of course, genetic pools can't change so rapidly. Now, these studies do point to education, the amount of time spent doing near work as being major environmental factors contributing to myopia development. But there's also some suggestion on the role of accommodation, blue light that I don't have here, and the protective role of outdoor time.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
All right, so myopia has existed for a very long time, probably as long as we can remember. So why now? Why are we kind of so focused on myopic management now? Well, amongst this, looming epidemic that is myopia, we have this obligation to kind of fulfill this role when it comes to managing myopia. Management of myopia is, I would say, several steps beyond just myopic correction, which is what we've been doing kind of all along, providing glasses and contact lenses to our patients. So now we actually want to help to prevent myopia onset and attempt to prevent myopia progression. And lucky for us, there is this huge movement and so much kind of happening around this important cause. Industry has partnered with researchers to provide more understanding of efficacy on myopia control options. They're actually inputting a lot of time and energy, resources into developing new myopia control options. Government organizations and international organizations such as the World Health Organizations are providing public health education and kind of increasing the awareness of myopia. Now, we have a long ways to go here, but it's encouraging to know that we are on the path towards kind of understanding more. Now, none of the treatment options that I've listed here can actually stop the progression of myopia, a very important concept to kind of understand and relay to your patients. But regardless of the treatment, we do expect some level of myopia to continue to progress. Our goal is just merely to slow down myopic progression, not to stop it completely. So today we're going to kind of focus on orthokeratology in the context of myopia control. And when it comes to thinking about the efficacy behind myopia control, there have been countless number of studies looking at myopia control in ortho-K. One of the earlier studies is this LORIC study, or longitudinal ortho-K research in children. Now, this was a 2-year long pilot study, being one of the first to really evaluate myopia progression after some anecdotal analysis that children fit with ortho-K were progressing less in myopia. So the authors looked at both amongst other things as well. They looked at both overall axial length measurements and vitreous chamber depths, and found that, as you can see from these graphs here, they found that there was a significant slowing of eye growth in the ortho-K group which is the white bars here, compared to the control group, which are the black bars, for both these types of measurements. Since the LORIC study, there have been numerous other studies across the globe in the US, Japan, Spain, Australia, that all show that children wearing ortho-K lenses have slower rates of myopia progression when compared to children wearing single vision correction. And then meta-analysis reports, which are essentially reports that take like a wide look at multiple studies to summarize the findings across a large number of studies, they have a very strict inclusion criteria. They've also shown overall that there's a 41 to 45% reduction in myopia progression compared to patients just wearing single vision correction. One of the more robust studies with ortho-K was the ROMEO study, which is essentially currently the only randomized control trial from all of the ortho-K studies so far. And this was over a 2-year period. They were able to find a significant reduction in myopia progression. The results are consistent with the meta-analysis values as well. The top graph here kind of shows the changes across every 6 months. The solid line is the control group and the dashed line is the ortho-K group. Time is across the x-axis here in months, and then the axial length is increasing across the y-axis as we move up. And essentially this graph here highlights that children wearing ortho-K lenses do show a slower axial length change compared to the solid line or the control group here. In this bottom graph here, open circle for ortho-K, solid circle for control group, you can see here in the scatter plot that there is quite a bit of variation. Some children tend to progress less than the control group and others at the same rate as the control group. The important take-home message here that I want to highlight is that yes, the 41 to 45% reduction is the average value, but it can't necessarily be applied to every child in our practice wearing ortho-K. And this message does need to be relayed to parents as you're educating them on the efficacy of orthokeratology. Unfortunately, it's extremely hard to predict how much each child will progress, and due to the tremendous variation in each of these children's risk factors, it's almost impossible to tell the parent exactly what to expect. Another topic of interest with ortho-K has been its safety, and you may have had discussions with your colleagues on the topic of this as well. And if you look at the history, that might have been for good reason, because in the early 2000s, there was this surge of independent case reports of orthokeratology and microbial keratitis. Watt and Swarbrick did an analysis of 123 cases of microbial keratitis in the literature since 2001 through 2007. And you can see from this first pie chart here that most of the number of these cases were from East Asia. And then from this graph here, you can see the peak number of these cases were from 2001. So these bars differentiate here the year in which the case reports of microbial keratitis were published, which is the black bars, versus the year that the cases actually occurred, which is represented by the gray bars. So the peak occurrence was in 2001. And then this last pie chart here shows us the type of infecting organism. And we can see here that Pseudomonas accounted for about 37% of these 123 cases. And interestingly and very alarmingly, acanthamoeba was implicated in 33% of all cases. Alarming because of how rare acanthamoeba really tends to be. For example, in a typical case series of microbial keratitis and other modalities, we might see a prevalence of 3 to 5%. So acanthamoeba at 33% is outrageously high. So what really was happening in East Asia in 2001? Well, as it turns out, the ortho-K contact lens market in China was unregulated in 2001. Ortho-K lenses for overnight wear were frequently made with non-gas permeable contact lens materials and fitted by untrained practitioners without access to appropriate clinical equipment. And tap water was sold as multi-purpose contact lens solution, so that kind of accounts for that high rate of acanthamoeba infections. Ultimately, as a consequence of this high incidence of microbial keratitis related to ortho-K wear, the Chinese government did intervene to regulate the ortho-K market, which resulted in fewer patients being fit with orthokeratology in general, but also fewer infections reported from this region since 2001 as well. So despite this apparent increase in reported cases of microbial keratitis in ortho-K since 2001, many of these cases occurred in a relatively short time frame in East Asia, but it left a lasting impression such that a lot of practitioners even today still haven't been convinced of the safety of ortho-K use. Because several subsequent studies have proven a fairly safe profile for ortho-K. Now, these studies further show that ortho-K is safe with careful monitoring. The bottom line here being, when it comes to the safety of ortho-K, is that if proper safety precautions aren't taken, there is that risk of microbial infections. But if the proper protocols and safety measures are taken, it is a relatively safe procedure to undergo in clinic for not only our adult patients, but of course our children, for myopia control. Now, moving on to fitting orthokeratology lenses. So let's get into more of the clinical application of ortho-K. Before we begin kind of the nitty-gritty, I just want to go over the lens design. So it is a reverse geometry lens design, and the goal of these lenses is to provide good centration uniform and predictable treatment zone. So one important aspect of fitting is to consider that there are those hydraulic forces of the tear film that are at play here, and that's what contributes to appropriate corneal reshaping. And so the goal is to have these ortho-K lenses land evenly and fully around the cornea. So centrally we have our base curve that is fitted, that is the most flattest curve, and it's responsible for the target treatment. Unlike conventional GP designs, the base curve for ortho-K has really no effect on fitting, but a major effect on the magnitude of treatment. The radius of this central curve is typically determined by the amount of corneal flattening needed to correct the myopic refractive error, plus an additional 0.5 or 1 diopters flatter to account for any regression, so that the patient can maintain satisfactory uncorrected vision throughout the entire day. There is actually, though this looks like corneal touch here, there is actually a very thin tear layer under the base curve here, less than 10 microns ideally. This creates this positive compressive force centrally. This reverse curve, the green arrows here are fit steeper than the base curve, so that when that positive compressive force is applied centrally, that will push these fluid forces and create kind of a negative pressure paracentrally here. And this pressure gradient will effectively pull the fluid from the cornea up and out. The amount of clearance in this area then depends on the amount of myopia being corrected. So lower amounts of myopia correction will result in a shallower sagittal height in comparison to higher myopic corrections. And then mid-peripherally here, we have this alignment curve, another point of very thin tear fluid. Again, this looks like touch here, but it's a milder compressive force than even the central curve here, which further serves to kind of seal this pressure gradient. This curve essentially brings the reverse curve back to the cornea. Ideally, this curvature should be this lens curvature should be a similar curvature to the actual mid-peripheral cornea, such that we have kind of that mild feather touch or the alignment pattern that can be seen here. It is critical for proper stability and centration of the ortho-K lens. And so one thing to keep in mind is that the more kind of positive compressive pressure we have centrally and mid-peripherally, the more negative pressure we have paracentrally. And so the more myopic correction we'll have and the more myopic effect we will have. The lens diameter also contributes to proper stability and centration, and then the lens power will depend on the base curve, but it will be the amount of it will be equivalent to the amount of regression factor. So if you're making the lens 1 diopter flatter than the myopic correction to allow for optimal vision as the day proceeds, your lens power will be +1 diopters. And then in our myopia control clinic, we perform a comprehensive data collection during our myopia control consult visits. So this list here is specific elements of that exam that I find helpful when I'm fitting or designing my ortho-K lens. So important aspects such as cycloplegic refraction, baseline corneal topography, the HVID measurement, and then the axial length measurements as well. So when it comes to choosing the initial lens and getting started with the first lens, 2 options exist here. So you can either fit your patient diagnostically or empirically. And some manufacturers do have fitting sets, so diagnostic fitting is possible. We have a diagnostic fitting set in our office, and so sometimes I do tend to go this route, especially if the case is going to be fairly easy. It allows me to evaluate the fit prior to ordering the lens, and I can make any changes as I need right then and there. Typically, I use less chair time this way. Overall, I do find that I can do, application and removal training that day as well, and I can go ahead and dispense that lens from the kit that day. And then when it comes to empirical fitting, really easy with the manufacturers being on your side here. You give them your topography, your K readings, your manifest refraction, your HVID, and they will design a lens for you. So the ideal candidate when you're selecting the patient, I'd recommend using your refraction and your patient's corneal topography to really guide your judgment to see if this patient is a good candidate. Your baseline refractive error matters because, of course, lower refractive errors are more easily correctable. And if you're starting out with ortho-K fitting, I would recommend kind of considering a cap. So say it's a cap of -4 where you're not going to go beyond that range, at least initially, to kind of get your feet wet with fitting ortho-K lenses. And then another consideration is your keratometry readings in relation to your refraction. So here we want to make sure we have keratometry readings ideally between 42 and 46 diopters. One thing to keep in mind is that when we're reshaping the cornea and the central cornea, depending on the amount of refractive error, so for any patient that has that moderate to high refractive error, we need to have enough corneal steepness for that flattening to occur effectively. So if you do the math and your patient's post ortho-K keratometry value is somewhere less than 38 diopters ballpark, the treatment may not be as effective for your patient. And then astigmatism tends to be a big limitation as well. Low to moderate amounts of, with the rule, astigmatism patients tend to be a lot easier to fit than higher amounts of astigmatism. Against the rule, astigmats tend to be harder to treat, as well as patients with a lot of internal astigmatism. They sometimes don't do as well, and they'll have residual astigmatism left over. And then pay attention to your corneal topography maps to see if there's a lot of horizontal and vertical symmetry when it comes to evaluating astigmatism. We want that astigmatism to be symmetrical. When we do have a lot of asymmetry and irregular astigmatism for any of these types of patients, then the corneal irregularities can play a big role in not getting effective treatment. One aspect that can sometimes be overlooked here when we're first starting out with ortho-K is not considering a toric ortho-K lens design when your corneal topography warrants this. So there are indications to look for, especially initially, even before you've started to do your fitting. I've been finding that I'm, using a toric ortho-K lens about 60 to 70% of the time when I'm really assessing the corneal topographer ahead of time. So again, for pre-fit conditions, you want to look to see how much corneal astigmatism you have. So if you have greater than 1.5 diopters of astigmatism, that may be an indication to go with a toric ortho-K lens design. And then kind of evaluating the type of astigmatism you have. So if you take a look here in this left image here, we're seeing, this is the dashed line here is your pupillary zone, and then you're seeing this astigmatism kind of extend outwards, kind of way past that pupillary zone. So we call this limbus to limbus astigmatism. Now compare that to this area here, where majority of that astigmatism is kind of isolated or contained within the pupillary margin. So here you have corneal or apical astigmatism, which is much easier to treat with orthokeratology. Elevation topography maps are helpful as well when you're determining whether a toric design is indicated. A sagittal height difference between the flat and the steep corneal meridians of about 30 microns or greater at the chord length of 8 millimeters means that a toric lens might be beneficial for effective treatment. So really take a look at your topography patterns to decide whether a toric lens is indicated, because you'll save a lot of headache when it comes to fitting. All right, another area of interest when it comes to working with orthokeratology, especially in myopia control, is what equipment to have and the equipment of interest. So technology, again, is an important aspect of myopia management, and depending on how full scope you want to practice will then justify, which pieces of equipment you'll carry in your practice. So one point I do want to emphasize here is that even though, you may not house some of these pieces of equipment in your office, it's still extremely important for you to understand the relevance and importance in managing myopia progression and orthokeratology. So these two pieces of equipment I would highly recommend, even if you don't have in your office, to send out your patient to get these measurements done at an outside office. Refer them out to an ophthalmologist that might have an A scan to get your axial length measurements, or talk to a colleague that has a corneal topographer to effectively manage these patients as well. But when it comes to fitting orthokeratology, having a corneal topographer, I couldn't imagine practicing without one. Assessing the fit. So for an optimal fitting lens, such as in this video here, you can see here a good goal is centration. And so in order to achieve good centration, if you have 90% of the lens cover the horizontal visible iris diameter, you'll typically get a good pattern, or a good centration pattern, I should say. The fluorescein pattern of an ortho-K lens should look like a bullseye pattern. So starting in and moving out, the central 4 millimeters of the fluorescein pattern should show touch. Again, remember, it's not actually touch, where we do have a thin layer of tears present centrally here. And then you should be seeing this paracentral area in the reverse curve of pooling. And so that zone will be about 1 to 2 millimeters wide. And then you'll have this kind of other, like right after the paracentral pooling, you'll have this mid-peripheral area of touch, or again, mid-peripheral alignment. And then lastly, you'll have a very thin, narrow band of clearance at the periphery, or at the edge, for the edge lift. So when you're evaluating the lens and the fit of the lens in an open eye condition, it's important to remember that this isn't really what the lens is situated like in a closed lens environment. And the only real way for us to get an understanding of what the lens looks like in a closed eye environment is to see the corneal topography. So the ideal corneal topography pattern will resemble a classic bullseye pattern, and it will be well-centered with a large enough treatment size to allow for comfortable vision for the patients. You can see here a symmetrical treatment ring or reverse curve zone that should also be well-centered, followed by an area of alignment curve that is flatter than that reverse curve. So when we're troubleshooting lens fits, and I'm going to go through this extremely fast, but when we're troubleshooting lens fits, it's extremely helpful to have an understanding of the topography as well. And so lenses that decenter can cause, visual issues, as well as corneal and conjunctival issues as well. So first up, with superior decentration, if that treatment zone is decentered superiorly, you effectively have a flat fitting lens. On the topography, you'll see the smiley face pattern on topography, which ultimately means that your lens is too flat, it's riding high. So the more superior this red ring is, the flatter that fit is. So in these cases, you're dealing with low sagittal depth, or too flat of a lens or reverse curve. So what you'll want to do is increase the sagittal height, or steepen that reverse curve. If you feel the edges are the edge lift might be too great, you can kind of steepen the peripheral curve as well. Other options include increasing the lens diameter and adding toric peripheral curves for better centration as well. The opposite to the superior decentration is inferior decentration, and the opposite to the smiley face pattern is a frowny face pattern that you see in inferior decentered lenses. And in these cases, the steeper the lens, the more inferior the lens is going to decenter. On fluorescein patterns, you might see kind of these bubbles trapped within the reverse curve as well, again indicating that that area is too steep. In order to fix this, we want to flatten the reverse curve or decrease the sagittal height. If the edge lift is insufficient, you may want to consider flattening the peripheral curve to again raise that lens as well. Sometimes if the diameter is too small, you can go larger in diameter, and then again you can always add toric peripheral curves if your edge lift is not consistently uniform. Lateral decentration sometimes can be really difficult to correct for because there's various different reasons for decentration, but the main cause tends to be too small of a lens diameter for the cornea you're fitting. So the fix here is to increase the lens diameter. Make sure you have about that lens covering about 90 to 95% of your horizontal visible iris diameter. A quick note here, there's several different ways to measure your HVID. You can use your corneal topographer. You can sometimes use slit lamps that have reticules that can be used to measure HVID. A simple other method is to use an HVID ruler like this one here, and a lot of manufacturers can actually help supply these for you. Central islands on a topography indicates that the fit is essentially too steep and that we have excessive sag. When this lens is too steep centrally, the cornea may steepen centrally rather than flatten, which is really what we're hoping for. Typically, these cases, we'll see a large amount of residual refraction and an unstable over-refraction. Sometimes it's important to keep in mind that when you're first initiating your treatment, you may see a few of these central islands, but they will resolve within 1 to 2 weeks. So sometimes you can just wait them out. But if these are persistent, that just means that you have too much vaulting over the apex and that you'll want to flatten the reverse curve and decrease that sagittal height. And you may need to flatten your peripheral curves as well if you don't have enough edge lift. Toric ortho-K, we kind of alluded to selecting this ahead of time if you know that there are some indications on the cornea that point to this. But one of the reasons why you might see a poor fitting lens, in terms of you might see some lens decentration, you'll see kind of this oval type of treatment zone, poor mid-peripheral alignment, or an incomplete treatment ring when you're looking at your topography. These are all signs that you actually have fit a spherical lens on a toric cornea. And so what you'll want to do is switch to a toric ortho-K lens design. And that should essentially help to fix any issues with kind of this unequal pattern on the cornea that you might see. So I did want to conclude with just outlining the different types of visits that you would need in a typical ortho-K practice. So during the dispense visit, we follow this protocol here, and I'm just going to quickly summarize this. So first, we prep the patient with topical anesthetic. We don't always do this, but I find that it makes the transition to wearing these lenses a little bit easier. We ensure that the lens is clean and disinfected, of course, before we put the lens on. We do use a viscous, non-preserved artificial tear in the lens bowl prior to insertion. We then check VA with the lens. We ensure that we are at our target vision. Our over-refraction should be plano to +1. We assess the fit. We conduct the application and removal training that same dispense visit. And then we discuss the care and hygiene in detail. We also provide, very well written instructions either from the manufacturer. We actually have our own as well. So we sometimes provide both. And then we also discuss any symptoms or any problems to look out for. And then we discuss, how to seek care if these symptoms do present when the clinic is closed or in a case of an emergency. Managing expectations is a key part of fitting ortho-K. So keep in mind that when you're discussing these with the patients, the rate of treatment will vary from patient to patient. So always give a big range. For lower myopes, it of course takes much less time than higher myopes. So on average, I say about 10 to 14 days. If the patient is a higher myope, I'll say up to 30 days or more. Most patients on a consistent schedule of 8 plus of nightly wear of ortho-K will show, proper target vision that will maintain throughout the day. And a lot of times you can kind of give patients soft disposable contact lenses to be worn in the interim, especially for higher myopes. So we do sometimes dispense, daily disposable contact lenses that the patient can wear in the interim. You do want to educate your patients on some level of induced aberrations that might show up, glare and halos, especially at night. These can show up especially when you're first starting the treatment. Most of the times the patient does get used to these. However, other times these can continue to last even after full treatment effect has shown. And then really quickly here, your follow-up schedule. This is kind of what it looks like. During day 1, we assess the lens and the cornea relationship. We make sure that there isn't excessive corneal staining and that the lens comes off easily, so there's not a lot of lens binding. And then we kind of follow this protocol. If everything is going, well, make sure you discuss this treatment protocol with your patients ahead of time in terms of the follow-up schedule. They should know that they'll be coming in for several different visits. And this is just the schedule if everything is working out well and you don't need a lot of lens fit changes. But if you are needing a lot of lens fit changes, then this schedule is actually even prolonged, especially around this area and this phase here. And then what we do at each of our follow-up visits. So I'll just kind of leave this up here so you guys can see in the interest of time. But one thing to keep in mind is although 20/20 uncorrected vision is the targeted endpoint, lesser levels of acuity can be acceptable depending on the patient's expectations and their goals as well. And then when you're looking at your over refraction, that should be about plus 0.5 to plus 1. So keep in mind that some of these, the over refraction kind of tends to fluctuate at each of the follow-up visits, but it should be anywhere between plus 1 and plano to plus 1, I would say. Lastly, there are several options for cleaning and care. We do typically recommend hydrogen peroxide systems, but a GP multi-purpose solution is also sufficient. The important aspect, again, is thoroughly explaining the cleaning process. We want to make sure that we're recommending the use of artificial tears and viscous non-preserved tears upon application as well, and some form of re-wetting drops to remove the lens, and that will help with any lens binding that's occurring overnight. All right, with that, I'd like to say thank you again to Contimac for having me on.